Good afternoon, everybody. First of all, I would like to thank the General Electric Company for the organization of this session about the Walant technique, a technique for surgeon but by anesthetist. I also want to thank the ESRA Society for the organization of the virtual congress. My name is S.BLOC. I'm a French anesthetist, and this is my colleague and friend Frédéric Le Sachet, a French anesthetist too. We work in Paris, France, in a private establishment dedicated to orthopedic surgery, so the clinic Drouot Sport in French, clinic Drouot Sport in English. I'm the oldest, so I will start with some slides to introduce the concept and the context of the Walant technique, and I will explain the reason why for 1 or 2 years we introduced the Walant technique in our practice, in our daily practice, how, why, and the benefits of this Walant technique for surgeon but by anesthetist. And after that, Frédéric Le Sachet will show you in a live demo how we perform some blocks for different kind of surgery, and we'll discuss about the technique we use. So about this technique of Walant, the Walant technique is the injection of a wide volume of local anesthetic, the lidocaine in most of cases. It's the tumescent anesthesia in the area of surgery. They add to the lidocaine epinephrine for hemostasis. In that way, they can avoid the use of a pneumatic tourniquet that could be sometimes painful for the patient, and they use epinephrine as a chemical tourniquet. And they perform this technique in awake patient. That's why the acronym is wide awake, local anesthesia, no tourniquet. This technique is described for 20-25 years by a Canadian surgeon, Dr. Donald Lalonde. He did a lot for to spread this technique for surgeons. He did a lot of studies, a lot of articles, a very good book, The Wide Awake and Surgery. You can find a lot of tips and tricks about this technique, and also develop a website about the Walant surgery. And this technique is clearly used by surgeons for different benefits, and the main benefit is that they can perform this technique not just in the theater but also in their office. So it's a concept of office surgery with a high level of satisfaction by the patient, and one benefit for the surgeon, the preservation of the motor function that could be sometime an help for their surgery. So why do we have to add this technique in the panel of our practice? First, because we clearly have the right environment to perform this kind of blocks. You can see in the right side of the slide some picture from a surgical study from surgeon, and they use this technique blind, so they inject first subcutaneously and after that during the surgery, because they can have some defect of anesthesia. So the right environment for anesthetist is first that we perform this technique under ultrasound, and Frédéric will show you that we probably make this technique safer using ultrasound, and we can also widen indication. Most of the time this technique is used for hand and finger and wrist surgery, but we can probably use it for clavicular, for foot surgery, for lower limb surgery, and Frédéric will show you some clips about this indication. Second, we clearly have some dedicated needle, hyperechoic needle, a very thin needle for the comfort of the patient, and we use a 24 gauge needle with a short bevel for this technique, and it's clearly very comfortable for the patient. The last reason why we clearly can use this technique in your daily practice is that we can mix or combine distal nerve block with Walant. Walant not as an anesthesia technique, but clearly as a chemical tourniquet technique, and I will introduce this point of view. We can also combine some medication, some drugs. Surgeons use most of the time just lidocaine, but in our practice we can mix long-acting local anesthetic and short-acting local anesthetic, ropivacaine and lidocaine, and we will show you an example of technique we use in our daily practice. So we clearly have the right environment. What are the benefits for anesthetist? The first benefits, and I will ask after Frederic about a result of a study we did on carpal tunnel relays. The first one is probably that we will improve the efficiency of distal blocks. The problem of distal blocks is that sometimes it's difficult to find to have the right indication. So which one do we have to choose? The second one is that there are a lot of variation, anatomical variation, a lot of anastomosis, and we can have some defect during the surgery, and we can need some sedation for the patient. Using in the area of surgery this chemical tourniquet, so this injection of lidocaine and epinephrine, you will probably make the efficiency higher when you combine distal nerve block and Walant technique. So first, optimization of our practice. The second is the use of the chemical tourniquets and the avoidance of the pneumatic tourniquets. What are the consequences of this chemical tourniquet? First, we can widen the indication of distal nerve blocks. Everybody knows that after 20 minutes, patients suffer or the pneumatic tourniquet is very uncomfortable for the patient, and that we have to choose very short surgery. But when we use a chemical tourniquet, so a tourniquet in the area of surgery, in that way you can widen indication and have surgeries that last more than 20 minutes. You can preserve motor function when you combine distal nerve blocks and Walant, just because when you perform distal nerve block, you preserve extrinsic muscles, so patients are able to move the finger if it's necessary for the surgeon. And the main benefits of the chemical tourniquets, the patient can move the forearm. In that way, it keeps the autonomy, and you will shorten the pathway because the patient is autonomous to take a snack, for example, to dress alone. Other example, to go on foot from the PACU to the room, from the room to the theater. So there is clearly a very high autonomy of the patient, and you shorten the pathway of the patient, and very probably benefits in terms of cost. About the chemical tourniquets, so instead of surgeon, we use a wide volume of lidocaine. We use a very low volume of lidocaine. Frederic will introduce that. No more than 5-7 mils with epinephrine to have hemostasis in the area of surgery, and we add bicarbonate to stamp the solution to make it more comfortable when you inject the solution. The knowledge we have is the knowledge of the surgery. We clearly need to know the different steps of the surgery to have the right injection of the chemical tourniquets, so lidocaine and epinephrine, and we have to well know the contraindication of this injection of epinephrine, and I will discuss with Frederic about this contraindication and how to make this technique safer with the use of ultrasound. One is the intrathecal shift injection, and Frederic will explain why it could be a limit. Just a slide to introduce the combination. So what we do every day, for example, here for carpal tunnel relays. So we perform distal nerve blocks, so median nerve, ulnar nerve, and we inject a low volume of lidocaine and epinephrine in the area of surgery. So this injection is clearly the chemical tourniquet. We don't need any pneumatic tourniquet for surgery. What is the benefits for surgeon? Because there are clearly a benefits for surgeon to have this Walant performed by the anesthetist. The benefits is the turnover of the patient. This is a very interesting study from Donald Lalonde. He assessed to onset time the optimal time for epinephrine effect. So he assesses or quantifies the blood loss after 7 minutes and after 30 minutes. And the result is that you clearly have to wait 26 to 30 minutes to have the optimal effect of epinephrine. So to have the optimal effect of a chemical tourniquet, you have to wait half an hour. So we perform blocks during a surgery by the surgeon, and after that, when the patient come in the theater, is clearly ready for surgery. So these 30 minutes is very important to perform block, and you have a very good turnover of patient. And this turnover may have an impact also on the cost, because we shorten the use of theater by the surgeon for surgery. So just to summarize the benefits of this Walant technique, so a surgeon technique but performed by anesthetists, we clearly have the right devices and the right environment, ultrasound and dedicated needle, probably to increase the safety of this technique. We can propose the right combination of block, distal nerve block and Walant to increase the efficiency and the comfort of the patient. We can use the right combination of local anesthetic, short and long, to have a short-acting local anesthetic for surgery and long-acting for analgesia. We will have the chemical tourniquet that will have an impact in the comfort for the patient and in the pathway. You will shorten the pathway, you keep the autonomy. And for the surgeon, it could be a choice, this Walant technique, because sometimes they need the preservation of motor function. And the second benefit is that clearly you will improve the turnover of the patient. You can find these different techniques we use on leaflet in French and English in your website. And I will just thanks also Payung that support this leaflet, and also the illustrator and the photograph of this leaflet, Theo Bolling and Charles Boissier, who help us a lot to give these very good pictures and very good pictures, anatomical pictures. So we'll go with Fred to show you how to perform the block, and I will try to ask him a lot of questions to well understand the benefits in terms of efficiency and safety.
So thank you, Sébastien, for this very clear introduction to the Walant used by anesthetists. I would like to share our knowledge, first of all, considering the increase on the safety done by anesthetists. For example, we use ultrasound probe, and I will show you how we do for a trigger finger release. First of all, we put the probe close to the palmar crease in order to see a very important structure for the trigger finger release, that is the flexor sheath of the finger. And I will show you on the ultrasounds. And the place where we are supposed to inject the mixture of lidocaine and epinephrine is just above, under the skin, and between the skin and the sheath, flexor sheath. For make it easily, I use the small needle in order to make no pain for our patient. I use my probe and I'm in plane approach, 1 centimeter from the probe, and I go slowly in the ultrasound plane.
One question, Frederick. Why not in the sheath?
Why not in the sheath? Because if you put the lidocaine, it's not a problem, but if you put epinephrine on the sheath, you have a risk of digital ischemia. It was reported in the medical literature, many around 5 to 6 cases of patients who received a blind injection, maybe in the sheath, with a diffusion on all the finger, and from the sheath there is a resorption close to the digital arteries that will be vasoconstricted, and that cause an ischemia and a necrosis. So it could be very dangerous to do it blinded. So we think that using ultrasound could improve the safety of the technique.
Another question, excuse me, there is no benefits to inject in the sheath. It's better to inject
above the sheath, there is no need. And if you see on this sonoatomy view, you have vascular of the digital anterior artery, and you have close small nerves. It's anterior nerves of the finger. There is no need to go on this structure. The most important is to inject 5 milliliters here above the flexor sheath. And this will be secure, and it will be very efficient for this kind of surgery. And you have to really understand, because we don't practice distal block on this kind of surgery, that if you don't inject on the plain surgical area, it won't work. The patient will feel pain. So it's very important to put the mixture really on the place where the surgical area is identified.
Okay, first
This is
one.
the first thing. The second
Another question: when you have, when you want to perform a circle injection for a surgery of the finger, do you use epinephrine? Do you use tourniquet? How do you perform your block?
No, for example, if we would like to do an anesthesia for finger surgery, it's very easy on the same image. You don't have to put the lidocaine or without epinephrine. There is no need to put epinephrine. You put some lidocaine or ropivacaine in order to have a long effect of the anesthesia, sometimes till 24 to 48 hours when
Very
you
long.
do a digital block. And you try to inject all the mixture here and in the other side, and it will make slip all the fingers. So the patient will be very comfortable. For the tourniquet, you have to put a digital tourniquet. Otherwise, the patient will feel the uncomfort of the arm or the forearm tourniquet. If we look at trigger finger on the thumb, it's almost the same. You have this view where you can see the flexor sheath, but it's not the place where the surgeon will work. So you have to identify the surgical plane area, and with the probe you go closer by following the flexor sheath. Here is the arrow, is here. You go upper and you will see the flexor sheath close to the artery and the nerves. And it's on this area that you are supposed to inject the mixture of lidocaine and epinephrine, because you are practicing Walant anesthesia. You won't use a tourniquet, and you need an ischemia of the surgical area in order to avoid bleeding. And it's working very well, because we conducted a study last year on carpal tunnel release that we'll see, and we identified that patients who benefit from Walant technique had less postoperative hematoma than patients who only had distal blocks.
And we submitted this study during the ASTRA virtual ASTRA meeting, so you can find the result of this study during the meeting.
So now, when we are speaking about carpal tunnel release, we need to speak about distal blocks. Distal blocks, there is 3 distal blocks that we could realize for the hand surgery. There is the median nerve. When you go up and down, you can see easily the nerve on the forearm. It's here you have the median nerve, going a little bit upper and down. You will have the ulnar nerve here close to the ulnar artery. It's here, this one. You can follow it going up and down. And you will have the superficial radial nerve, which be in charge of the anesthesia of the thumb and the dorsal face of the hand. When you look, it's a superficial one. It could be close to the artery. Okay, and when you go up and down, you can see it easily. And you can identify the structure. And if you want, if you are not comfortable at the beginning with distal block, because it's not always really easy to identify which nerve you should do for what kind of surgery, you can do both of them, the 3 with 3 to 5 milliliters on each nerve. And you can choose lidocaine for a short effect, short acting effect, or ropivacaine or chirocaine for long acting effect. For example, if the surgery could be painful, if the surgery is painful, you can use ropivacaine. For example, for a 5th finger fracture, it's very interesting to use an ulnar block here with ropivacaine, and then doing a Walant on the, we will see this a little bit later on the movie clip, and doing a Walant here on the place where the surgeon will work in order to avoid tourniquet on there. And for the carpal tunnel release, if you want to see where we have to inject during Walant anesthesia, you will have the pulmonary artery here that you can see. The medial nerve is going just under the transverse carpal ligament, and the place where you have to inject the lidocaine with epinephrine is all the areas that Sébastien is showing you, where you inject between 5 to 7 milliliters of lidocaine and epinephrine. Why we have to inject epinephrine? If you don't put epinephrine, it's not Walant. You will need a tourniquet. If you do distal block and only lidocaine on the carpal area, it won't work. You need to associate lidocaine and epinephrine.
We talk about the efficiency, and in the study you talk about there is clearly a better efficiency when you had distal nerve block and Walant.
Yes, because in the study we did, we associate a median nerve block with an ulnar nerve block, which is a classic association. Many years ago, we did only these two nerves and a small injection here because you have the cutaneous forearm nerve, lateral and medial, and it's not coming from the same area, it's coming from upper. So we had these two injections and here, but sometimes patient could feel something during the incision, during the surgery. And because now we do the Walant, we improve and we don't need any more any dosage of propofol, for example, to any sedation to decrease an uncomfort for our patient.
Thank you, Frédéric. So Frédéric will introduce some clips we did in our structure just to highlight the benefits of this technique.
What we would like to underline is that Walant is not only a technique. It should be included in what we call an optimized pathway. I will show you a short clip about what we offer to our patients when they come in our structure for a carpal tunnel release. And you will see it go very fluently from the beginning. And from their arrival, it's 2 p.m. The patient is arriving, there is an admission. Then he will arrive in the pre-operative room where we work for the anesthesia. Then the patient will go to the operative theater after the administration of local anesthetic and the performing of Walant anesthesia. You can see it in this movie. Then the surgeon will be able to work to do the surgery around half an hour after, in order to wait for the Walant to be efficient on the ischemia, because we need an ischemia in the area where we did the Walant. And you can see the surgeon is doing an endoscopic surgery. Then the patient can leave the operative room with an autonomy, can move his hand. It's very different from axillary block, which is so used in France, and then he is able to eat, to drink alone. And 59 minutes after, he will leave the structure. He will benefit from the safety of the anesthesia, of the comfort of the structure, and the accuracy of the surgeon. And we really want to understand that it's very important to consider the whole pathway. It's not only a technique. Then we have this kind of video where we associate long-lasting anesthetics. It's ropivacaine on ulnar block, because this patient had a fracture on the 5th finger. And you will see the association, the combination of an ulnar block, an in-plane technique close to the ulnar artery, and you can see the local anesthesia diffusion. And then with lidocaine and epinephrine, we do a 5 milliliters infiltration just in front of the fracture where the surgeon is going to surge. Then the patient is able to walk till the operative room, and you will have a totally normal surgery where the surgeon will test his reparation, and there is no tourniquet. The patient has still a sparing motor block, and he can move his hand. Then you will discuss a little bit with the surgeon, and he will go back to his room. So it's very interesting to change it's really a game changer. Instead of realizing only axillary block that's so common in our daily practice, we can start to improve our practice to increase the autonomy of the patient. And because in anesthesia we are not only working with hand surgeon, we can also extend the indication of Walant, for example, for implants removal. In this young patient, there is both 2 legs implant removal, and we did in a Walant. It's very important to stress the fact that we have to inject the local anesthesia in front of the implants, but also in the back leg, because the screw you can see is a big cortical screw. So the patient, if you don't make the both cortical anesthetized, your patient will feel the screw when it will be taken away. And after this surgery, you can see easily the screw with the ultrasounds. And after the surgery, that usually is done with general anesthesia or spinal anesthesia, the patient, in our case, was able to walk and to go back into a room directly, because she had a local anesthesia around 45 minutes before the surgery. So I hope that you enjoy our presentation, and we will answer all the questions that you could have on this topic, and we hope that you will find Walant technique as a new possibility, different of axillary block for hand surgery. Thank you.